Do we have the next speaker's video? Ravi Dev? So we have completed all the talks now.
Yeah, I think so. Yeah.
Yeah, Professor Ramanian.
Thank you.
Yeah, it was very nice talks in generally as usual we discuss on this subject, adult degenerative deformities. We always discuss this with lot of interest because it is one of the tough subject in spine and tougher subject for neurosurgeons to adopt in recent years. When I look into these talks, as we had earlier also, both in WFNS and also in India, we had quite many things still not answered very well. But now that we are there with all the specialists, I have a few things really, unfortunately, Rick is not there because he was supposed to present on the minimally invasive techniques in deformity, in degenerative deformity. It would have been very nice. But now since it's not there, very difficult for us to discuss much on the MIS techniques. I just wanted to, the way the trends are going, do you all feel that we are going to instrument these patients less and lesser? Number one. Number two, will we be going back to the hooks than the screws, the pedicle screws? Because there are some discussions, to prevention is more important than performing. In prevention, there was a suggestion that we can put hooks on the upper level, which will reduce the junctional failures. So this one particular thing I really wanted to know from the experts before we can discuss on further.
Yeah.
Yeah.
So can I go ahead?
Yeah.
So basically, when you're using hooks terminally, so you're not going close to the midline. So there is less chances of injuring your facet capsule superiorly, your interspinous and supraspinous ligament superiorly. Because if you want to even insert a pedicle screw at the top, you need to do some dissection to get around that entry point. So in that effort, you end up injuring the capsule and sometimes possibly the supraspinous ligament. This especially happens in scoliosis because when you're taking an incision, sometimes your cautery doesn't follow the spinous process, and inadvertently you damage the interspinous ligament. So keen you have to be very extremely sharp when you're doing your dissection superiorly, and I usually don't allow my assistants to put the superior most screw, even if I'm not putting the hooks, so that I usually tend to direct the superior most screw inferiorly, so that it doesn't irritate the superior end plate and incite a reaction there, and which can sow seeds for a PJF or PJK later on. And with regards to fusion and non-fusion, I have always been a champion of non-fusion. As much as possible, we tend to avoid fusion, especially the best example would be degenerative spondylolisthesis or a degen scoli with just radicular pain unilaterally, which is not very flexible. In such cases, it's better to go stepwise. Even if you can pull about 5-6 years with just decompression, later on another day you can do a fusion there.
Okay. Yeah, see, this is the point which always ponders around most of the scoliosis surgeons, particularly in degenerative scoliosis. I'm not talking about the softer one, but degenerative, because we were fascinated with earlier days, but large number of pedicle screws in every spine. It's going to be correction, but if it is a soft scoliosis, correction is very good. You need a lot of screws, but in degenerative, because I have seen that a lot of papers and many presentations which are coming with lesser and lesser pedicle screws. But that's one thing which is really fascinating.
Yeah.
As you rightly pointed out, you delay the fusion. What you're trying to say is that if it is symptomatic, you delay the fusion. Am I
Can I
correct?
comment on this,
Arvind?
Jyoti?
Yeah, please.
Actually, the more rigid the fixation is, the more common the problems. So because of that, we are resuming our talks by saying that shorter fixations are better. Another thing is probably upper and lower level mobility, so then hybrid systems. Because if you make very rigid fixations, the more loads are coming on the upper and lower ends. So one of the reasons of screw loosening in the upper part especially is because of rigidity. The other one is the osteoporosis. Two reasons. And if you fix with hooks instead of spongious bone, because the hooks are anchoring on the cortical bone, you are then making a more secure fixations.
Yeah.
Thank
So
you.
it looks like any other comments from the faculty?
Jyoti, may I say something?
Yeah.
Onur
Salman,
Yama.
where are you?
Onur.
Hello?
Jyoti Onur.
Honor, yeah, please.
Yes. First of all, I'd like to say that we have to decide the type of the surgery that we're going to do. If you're doing only decompression surgery, 2014 or 15, Lamartina and Periano has published a paper. We don't have to correct all the degenerative scoliosis cases. We have to decompress them, but if the patient has sagittal plus coronal imbalance, we have to correct them. So it's 4A and it's 4B according to this classification. But if we don't have to correct it, let's say the patient has a degenerative scoliosis and the reason of the back pain is lumbar stenosis at one level, only decompress that level, and if you don't need, do not put any screws there. But if you're doing a deformity surgery, you have to say 40%, as Zilali said. First of all, the complication rate is 40%, the reoperation rate is 40%, and 40% is pseudoarthrosis. If that patient accepts this complications, then you can do the surgery. But if you do the surgery, if your choice is minimal, let's say less segment, but if you're not doing it proper, you will fail. You will have, as Arvin told us, you may have junctional failures. So all neurosurgeons have to learn the sagittal balance concept, because without knowing that, you don't have to do the surgeries. Because if you do a surgery, not talking about adult degenerative scoliosis, if you operate the patient and give not the proper lumbar lordosis there, you're starting a deformity. I'm not sure whose words are there, but they say that every spine surgery is a deformity surgery. Someone create the surgery, a deformity, someone solve the deformity. So we have to know the sagittal balance concept. Maybe the hybrid system is one solution. And according to the last literatures, they say that minimal invasive allows you to decrease the segments. So we have to learn the lateral infusion techniques also. Thank you.
Thank you, Anur. I saw your cases because your cases are more extreme type of cases which you showed, which is very good. I just wanted to ask you a few things, like will you be doing the minimal type of osteotomies which you've done, like facetal removal, in majority of these cases or not?
Beauty, the answer is that if you can do, first of all, we have to make a surgery plan before the surgery. So you decide which osteotomy type you will need. If you have the chance to get the sagittal balance with multiple ponte osteotomies, with little osteotomies, do that. Be aware of pedicle substruction or corner osteotomies because most of these cases are osteoporotic and they have problems. And if your osteotomy goes to distally, you have to go to the iliac veins. Now, in our daily practice, we are using double rods to prevent the distal junctional failure. But using double rods, I'm meaning 4 rods, to one side, to one side. Now I'm thinking that it's not the solution. Let's say that if a patient has a severe SVA, you have to make a osteotomy to the distal part, let's say to L4. Because of 2 reasons, if you do the osteotomy to distal, you can bring the patient more back. And the second reason is the lumbar lordosis is 60% of lumbar lordosis is at L4, 5, L5, S1. If you do a osteotomy L2 at 2 level, at L2, you will not have a proper lumbar lordosis. So you have to do the lordosis to L4, sometimes to L5. Then you have to go to iliac vein. So you're starting another problem. So you have to know the biomechanics, but all neurosurgeons, this is not only the orthopedic surgeon's issue. If you do a surgery, it's not about deformity. If you do decompression, if you're doing listhesis, you have to know the sagittal balance idea. We all have to learn it.
Yeah, yeah, oh no, correct. Because this one particular thing, like particularly that the neurosurgeons are very good in instrumentations now, but then correction osteotomies, I personally feel, still has not reached to the that kind of peak. Sajesh, we were discussing, Menon, and we were discussing earlier about this kind of, so when we do the soft scoliosis, it is quite different. But when we do the degenerative deformities, which is very common, most of the patients, a lot of patients, they have degenerative deformity in elderly patients who come with a canal stenosis or with a radicular pain. Invariably, you you feel like then you like to correct it, but then you know that you need to do a minimum surgery. But when we do the minimum surgery itself, the patients are quite good. Often they look very good because, if you see the patients who are coming from the villages, they are very strong. Their bones are a little bit stronger. I'm talking about villages who are coming from Indian villages who are working very hard on the soil. They look pretty hard. Except the osteoporotic patients, they are more from the urban people. So I always used to feel that how much of these osteotomy techniques need to be inculcated or slowly get into the neurosurgical arena, because facet removal is becoming common nowadays. Because of the development of T-leaf, particularly in the lower lumbar region, that particular technique has become pretty much popular. Or T-leaf. Earlier we were doing P-leaf, now T-leaf is becoming common. Then you like to correct on one side, on the other side. But if you do the same facetectomy at multiple level, you have a more chance of correcting to a reasonable. But then the kind of Pontis, the kind of the VCRs, they are a little bit more tough unless we have good training. I think what Sajesh, you have to tell, because he is the one who has mastered both the thing, because basically he has been trained in orthopedic surgery and also a neurosurgeon. Sajesh, you're muted.
Basically, we have to learn the osteotomies. That there are many ways you can do it. You can start with the Pondis initially. Pondis is not a difficult surgery at all. Once you have done that, then you can can graduate into the other osteotomies like pedicle subtraction osteotomy. Pedicle subtraction osteotomy itself is not a difficult one.
Yeah.
You have to identify the pedicle, you have to dissect laterally and get into the pedicle, and you can curate out most of the cancers bone, especially in osteoporotic patient. It is not a difficult job. You don't have to drill at all. Probably you can get curate out, curate itself can get you there. And then this is just matter of compressing the elements, so there will the cortex will compress. You have to compress the cortex, and you can do it. But there is most of the neurosurgeons has got a mental block because they won't go beyond the canal and going to the anterior part of vertebral body is there is, I don't know why, there is some block for them.
Yeah.
There's a this technically, if you can do do pedicle screw, you can do the decompression, you can do laminectomy, you can, if you can do vasectomy, it is probably a next step is to do a the corpectomy, and you are doing corpectomy in the cervical spine, the left and right, and most every day. Then going to the lumbar or a thoracic spine is a bit of
Yeah.
concern for everybody. That is probably a mental block. It is not a difficult thing as you ask everybody.
Yeah. Maybe the generations coming now may change the ideas, because the seniors may like it difficult to go beyond a certain line, but the new generations, because I personally feel that scoliosis surgery is very much increasing among the neurosurgeons now, particularly with the new like majority of this age neurosurgeons are into that. And I'm very happy the way the cases shown by Onur, Arvind. I've seen Arvind's earlier talks also on this particular subject. It is always very interesting, particularly at the proximal junction kyphosis, because it's very common. We tend to, because we learned putting the pedicle screws everywhere in pedicles, in thoracic and everything. But then finally, as Mehmet showed one case, you start with one level and then junctional problem at another level, then another level, then another level, then it goes up to the T2 or T3, that's a very nice case which is showed. So certainly that aspects has to be learned by the younger generation neurosurgeons. I'm very happy that the session went on well. In fact, that we have more time. If Jileli has any other points to make it on this subject, please come forward, please.
Yeah. Thank you for opening that subject with osteotomy. Actually, on one hand, we need to make not to make too much forces for correction maneuvers. If you apply too much forces, since the bone quality is not good, osteoporotic, then your screws may get loosened during surgery. On the other hand, you need to correct some deformities with interbody fusion or osteotomies. But osteotomies are bloody surgeries. For pedicle subtraction osteotomy and multiple level fixation, average blood bleeding is about 1,500 milliliters. Yeah. This is too much, and the patients cannot tolerate that much. MIS techniques may be a solution, but it is time consuming. So these are dilemmas of the geriatric spine deformity surgeries. On one hand, we need to make some osteotomies, but since it is bloody, we must not make them too much. Thank you.
Thank you. Thank you. Arvind, Arvind is there? No, I think he has gone. He's not there.
Can I say something, Jyoti?
Is there anything, any more comments from the
Jyoti?
faculties on this subject?
Jyoti?
Yeah.
Following Zilali's words.
Yeah, Onur, yeah.
Yes. Zilele has shown a case, as
Yeah.
I told before. If you're not doing the surgery correct, you're starting a deformity. In that case, the lumbar lordosis after the surgery was not perfect. So you get a proximal junctional failure. Then you have to go one more above. The solution is not going above. You have to go to the lumbar area and
Okay.
you maybe need to make a osteotomy there. Then you have to get a proper lumbar lordosis having according to pelvic incidence. So before the surgery, you have to, let's say the patient's pelvic incidence is 50 degrees. During the surgery, the patient has to get 50 degrees lumbar lordosis. If you give it 40 degrees lumbar lordosis, it will fail. You're starting a deformity now.
Okay.
So using pre-bending rods means you make all the measurements. You know, you have to give a lumbar lordosis for 50 degrees. During the surgery, you have to put the rod without forcing it. You only put it there. And using the osteotomies, do not use any compressive forces. Only deflex the table, especially in pedicle substruction osteotomy. Don't try to compress and try to close the posterior wall. Only deflex the table. The problem that we're having in osteotomies is bleeding, as Zilali said. So minimal invasive is one of the solutions, as OLIF or XLIF. But we don't have any pseudo arthrosis at the osteotomy site. We don't have any problem in above or below the osteotomy site. We have problems at the proximal part or in the distal part. So going to iliac wings is not a solution. You have to put an interbody cage in front because we're using 4 rods now. Still using 4 rods, it still fails. So another solution is going to 6 rods, maybe. But without using interbody cage, it's not a solution. Thank you.
And that's a good point. See, ultimately, we come to the basic. I think we have to start learning putting the lines for all cases of even if it is a simple case of a lumbar degenerative spine. That becomes the final end because I saw this point which Sajesh made. PI minus LL is more important than PI is equal to PT and SS. Sajesh, are you there?
Yeah, yeah, very much.
That point was very interesting.
Yeah,
Pelvic incidence minus lumbar.
minus lumbar lordosis mismatch.
See,
As
these kind of concepts have to be driven among the neurosurgeons because that's one problem. Now, what Onur said was very interesting, saying Jaleli's that case, which showed that it's breaking up and up again because you have not corrected the lumbar lordosis. You have not seen the lumbar lordosis. If that was kept in the mind, this may have been prevented. So, can you tell more about this PI minus LL and the importance more than the PI is equal to PT plus SS? Sajesh.
yeah, okay. See, as Noor also told, if you have a lumbar lordosis of 50, he was just mentioning, and PA is if the PA is 50, the lumbar lordosis you should make it 50, because if PA minus L should not be beyond 10 degrees. It should be within that 10 degrees. You don't have to do the exact like, but it should be in the within that limits. Should not go beyond. The difference should not go beyond 10 degrees. So first thing you have to know is the PA. That can be the problem is most of the degenerative patients we were not doing a standing X-ray. The patient usually come with a X-ray in the supine position, and we are calculating with that. But in case of AIS, adolescent idiopathic scoliosis, we will always send the patient for a standing X-ray. But here also, our practice you have to change your practice. You have to get a standing X-ray. Then only we can get the correct PI. Then only we can do the calculation. So that is the most important point. Second, once you have that calculation, The second difficulty is that how much say if you want to make a lumbar lordosis of 50 during the table, it is not always easy to measure. You have done your osteotomy, whatever it is, you got that much of correction. That is also a difficult issue I I faced during. Most often we take it by eyeballing only. We just see it and we think that this is 50. And when you
Your
come,
voice not clear.
most often we do the eyeballing technique. We see it and okay, this is almost 50, but that may not be correct. When you go back and the post-op X-ray, when you see, it may not be 50. I don't know how that problem can be solved. Most often we can err during
Yeah,
the
Onur.
table, although
Looks like Onur has an answer. Please tell me,
The
Onur.
answer is that Menon, if you have decided to fix that patient from T10 to L5, okay,
yeah,
you can use pre-bending rods. You can calculate it on SurgiMap, okay?
okay,
You give it, let's say, you
mm,
need a 15 or 20 centimeter rod. You bend it. The software
okay,
allows you to get the 3D print of it. You give it to the medical. You'll say, or you can do it your own, or your assistant can do it. You bend it before the surgery, okay? Now you have
okay,
a pre-bending rod.
yeah,
So you make your osteotomies, then you put that rod inside it. You don't have
mm,
to force it.
right,
You don't use any rocker. You don't have to use any persuader there. So if the rod goes it very easily, it means this is the surgery that you have planned before the surgery. The answer is
Okay.
that.
Yeah.
yeah,
And
Oh,
about pelvic incidence, Juti.
yeah.
Pelvic incidence is the, uh, let's say, fingerprint of a patient. Okay? Everyone has to think like that. You have a shoe market, okay? The only number of the shoe you has 40, okay? Jutta is coming, you're giving a 40-degree number of shoe. Menon is coming, he has 42 numbers foot. He say, yes, I have only 40 number shoes. You cannot put common lordosis to every patient. Every patient's pelvic incidence is different. It's the footprint, fingerprint of a patient. We have to know it before the surgery. So if the patient has 60 degrees pelvic incidence, let's say this patient needs 60 degrees lumbar lordosis. Without doing it, getting a rod and bending it, let's say, yes, it's normal. According to what? You put it there and you start to get deformity, a new deformity. Thank you.
Okay.
yeah. Well said, well said. Thank you.
Yeah, so Jyoti, I want to add to this.
Arvind, yeah.
Yeah. So again, this PL minus LL is not fixed for all the age groups. You see, then you'll have junctional kyphosis. That's what I said. When you're trying to get a 80-degree patient to have a profile like 30 degrees of a 30-year-old, then you'll have junctional kyphosis. So if you see that that particular, it is a published article where they've seen the health quality of these patients, ODI of these patients across all age groups. So if you see the PL minus LL, which keeps changing with age. So sometimes it could be as high as minus 30 degrees in 80-year-old. Otherwise, if you try to get it close to PI in a elderly age patient, she'll get into junctional kyphosis. So
Okay.
you have to match it age wise.
Arvind has right. It's not a proper number. It changes to age. We're talking commonly. Let's say it's nearly 10 degrees, but according to age to elderly people, this numbers comes down. So you have to know that. So you have to calculate everything before the surgery. So the softwares are because of that. They give you the age, they ask the age, they give the, let's say, common proper lumbar lordosis, and you're trying to rank that patient according to that limits according to age.
Yeah. Well, thank you very much. It's really wonderful to have this subject again and again, and I would recommend the faculties to come back one more time maybe to teach all the Indian young neurosurgeons to get into this. And I also making the point that this basics is more important than trying to correct in a very aggressive way, over enthusiastic. Because surgical wise, you are mastering, but the basic, unless we understand the real basic, we are not going to do the justification. So in fact, that I have to conclude now because of the time. I thank all the WFNS Spine Committee members for taking much time to join for the NSSA meet. It's a very important national meet for us, and we can do more in future. We can also have maybe workshops on adult deformities. We must have a step-by-step workshop. That's what my feeling is, that we should have in coming days a classical workshop, so that we understand this subject better and better. Thank you very much for all of you. I thank you on behalf of Dr. Mani and the NSSA. I thank all the faculties. Thank you very much.
Thank you, Jyoti, for giving the opportunity.
Thank you. Thank you.
Thank you.
Thanks a lot. Thanks a lot.
Thank you. Thank you. Thanks a lot. Thank you.